Good evening, ladies and gentlemen. My name is Russ Thomas, and I'm the CEO of the Prostate Forum of Orange County. It is our pleasure tonight to bring to you one of the highly regarded speakers that we provide for your information pleasure the fourth Thursday of every month.
Dr. Lam is a board-certified internist and oncologist. He has been specializing full-time in the treatment of prostate cancer since 2001. He is Director of Clinical Research at Prostate Oncology Specialists Incorporated in Marina del Rey. Dr. Lam has written numerous articles based on his research. He is a member of the American Society of Clinical Oncology and the American Society of Hematology. Dr. Lam continues to promote prostate cancer awareness and education by giving lectures at various medical conferences and prostate support groups throughout the country. He received his undergraduate degree in biology, magna cum laude at UCLA. He earned his medical degree at UCLA School of Medicine before completing a residency, specializing in internal medicine at UCLA Center for Health Sciences. So, I ask you to please welcome Dr. Richard Lam.
Hello, everyone. So, I think 16 years ago when I first started in prostate oncology, one of my first lectures at a support group was here. And I remember my first talk, I was like, oh my gosh, I'm so nervous. All these patients who are, well-read, they're educated, and I hope they don't stump me. But it's no, perfect, and I've learned over the years, coming back here multiple times, that it's a wonderful experience, and meeting all you gentlemen here and wonderful ladies, that it's a real big honor for me to be here, especially on this 25th anniversary celebration. So again, thank you very much for having me here. So let's see. So 25 years ago. Can anyone interpret this? So prostate cancer was a field which I characterize as 50 shades of gray. So not the sexual part, but there was nothing was black and white. Everything was controversial, and patients would be given all these different opinions, and they just did not know what to do. And their leaders or their doctors were, take your prostate out. And so that was, it sounded like black and white, but when you dive into it, prostate cancer is especially back then, was a very nebulous field. And so in the last 16 years, or in the last 25 years, things have become, there's a lot more emphasis on research in prostate cancer, and we're definitely learning a lot more. And so after tonight's discussion and lecture, hopefully we have a better sense of black and white in terms of various stages of prostate cancer management. So it's a big field. There's guys who present with various types of situations. You can have low risk prostate cancer, all the way up to relapse disease, metastatic disease, and now there's treatments with immunotherapy and radiopharmaceuticals. So this is basically what I'm going to cover tonight, trying to incorporate the most recent research and new standards for various types of conditions. So hopefully everyone in here will hear something that applies to their own specific situation. So a little bit of background on prostate cancer, which I think is still important to know. We diagnosed about 180,000 men last year, and it's still the most common cancer diagnosed in men, other than the safe skin cancers. It represents about 1/3 of all the cancers diagnosed in men. The risk of lifetime risk of a man being diagnosed with prostate cancer is about 1 in 7. And as of 2013, there are over 2.8 million men living with prostate cancer. A lot of people live with it, and fortunately and unfortunately, there's still 26,000 men per year have to succumb to this disease. So let's talk a little bit about the most recent findings on low-risk prostate cancer. So low-risk prostate cancer is characterized as someone who has a PSA of less than 10. Their digital rectal exam has no nodules or just a tiny nodule, that's T2A. The Gleason score is 3+3, and in select patients with Gleason 3+4 disease. The number of cores involved is less than 25%. So 2 out of 10 cores, 3 out of 16 cores, less than a quarter of the cores that were taken are involved with prostate cancer. Now we're doing genetic testing, and there's good and bad genetic testing results. And usually these men, if we do some sort of imaging to look at the prostate, we usually don't see a lesion, or we see only a very small lesion. So you guys probably know all about the typical treatments for prostate cancer of the low-risk category, and these include the following: external beam radiation therapy, seeds, surgery, cryosurgery, and now something called high-intensity focused ultrasound. Also, it's important to know that one can manage early-stage prostate cancer with active surveillance. The systemic therapies, we try to, the patients do not need these types of treatments. So what is active surveillance? Active surveillance is it's an approach to low-risk prostate cancer where one avoids treatment for now, and we're safely monitoring early-stage prostate cancer, and only treating these patients when the cancer shows some sort of progression. Okay? So we're still keeping in mind that we want to cure these people, but there doesn't appear to be an immediate need. And it could be anywhere between 5, 10, and 15 years before one needs to get rid of this cancer, especially since we're assuming it's going to grow very slowly. Okay? So this is not what I call palliative approach. It's not like, oh, well, you're old, let's just let the cancer keep growing, and if it causes some problems, we'll give you some hormone therapy. This is still an aggressive approach, but just not invading the prostate too quickly until there's an absolute need. Okay? And why would one not treat cancer? Okay? Well, the treatments for cancer could be very life-altering. It could affect your quality of life. Occasionally, it could even be deadly. You could get infections and surgical complications, anesthesia risk, heart attacks. So treatment is not a benign thing. So if the cancer is growing slowly and we want to wait for better and nearer solutions, active surveillance would be a good option. Of course, this allows the patient to maintain his quality of life. And again, we're still going to cure you, but we're going to cure you when it's absolutely necessary. Okay? So usually we pick candidates for active surveillance if we think the cancer is going to take a long time to become serious. So if we think it's going to become serious in 1 year, then we probably don't want to do active surveillance. You're only going to get 1 year of peace and quiet. If we think the cancer is going to grow over a period of 15 years before it gets worrisome, then you get 15 extra years of keeping your prostate. Now, that's a big win. So don't confuse this with watchful waiting, expectant management, deferred therapy. So over the last 15 years, active surveillance has become much more common and accepted approach. It's not just in university centers, but in the general population, up to a third of men with lower risk prostate cancer have chosen active surveillance. Again, the criteria for active surveillance are all the low risk categories that I talked about. No nodules, low PSA, Gleason scores favorable, favorable findings on ultrasound, favorable findings on genetic testing. Okay? How do we look at the prostate? And why do we look at the prostate? So when we do biopsies, typically patients undergo these random biopsies, and random biopsies by definition may miss the cancer, or it may not really diagnose or sample what is truly the situation. So we do ultrasound or MRIs to look at the prostate to make sure there's not more cancer than what the biopsy suggested. Another way of putting it is the favorable biopsy really indeed representing a little bit of low-grade cancer, or is it actually just representing the tip of a giant, terrible iceberg? So we rule out the iceberg by doing good imaging. So one of the popular types of imaging would be just a color Doppler ultrasound. And that's a quick procedure in the office, and it's basically using sound waves to look at the prostate. And in this picture, I'm going to show you, this is a prostate, and these two pictures are identical, except the picture on the left has little blood vessels signifying blood flow. The picture on the right is the prostate without blood vessels. A normal prostate on ultrasound is usually a grayish color. Okay? Cancer could often look like a little dark spot. Okay? So in this gentleman, who has on the surface, he has a Gleason score of 6, PSA that's low, no nodules, and we do an ultrasound, and we see a small 7 by 5 millimeter lesion. Sometimes we see nothing. Then we're saying, well, this indeed is not that much cancer. Okay? So we could feel safe to monitor the patient. Okay? On the other hand, if the same patient came in and has a larger dark spot, such as this one, which is about 15 or 16 millimeters, and it has a lot of blood flow within the dark spot, this is the iceberg that maybe the biopsy only sampled that nicked the corner of the cancer, but it didn't really get diagnosed or correctly classify this type of cancer. So this patient would not be the ideal candidate for active surveillance. Another way of looking at the prostate is using an MRI. There's many centers of excellence now that do MRIs, and this is a little bit more complex procedure, but it's still very doable. And basically the patient is laying down, and his whole body goes into the machine, and the MRI machine looks at the prostate. Okay? Takes a little longer, maybe 45 minutes to an hour, and the results take about 2 to 3 days. And on this MRI picture, a normal, healthy prostate looks like this. This is abnormal prostate. This is cancer. So this would be not a candidate for active surveillance. Okay. This is another patient with a lesion at the front of his prostate, which sometimes the biopsies don't even hit. And this large dark spot, being the cancer, is a little bit too big to do active surveillance. So with that in mind, if a patient is a good candidate for active surveillance, active surveillance is an accepted option, strategy, as endorsed by all these medical groups, the AUA, NCCN, which is the National Cancer Network, ASCO, which is the Society of Clinical Oncologists, and this is the European Urology Association. So there was a big trial to really prove that active surveillance is a safe option. And this was presented in the New England Journal 1 year ago. And this was the trial that was done in the UK. And it's called the Protect trial. This trial screened about 80-something thousand men, and they found 2,600 men had what we call localized prostate cancer. And they're all low risk, a little bit of medium risk patients. And about 1,600 of these men were willing to be randomized. Randomized meaning a third of them underwent surveillance, a third of them underwent surgery, and a third of them underwent radiation. Okay. And let's see what happened to these men. Okay. The average PSA for this group of men was 4.6. The age was 62, so fairly young group here. And three-quarters of the men had Gleason 3+3, and the other quarter of the men had Gleason 7, essentially. And most of these patients had no nodules on exam. The ultimate goal of the study was to look for the risk of dying from prostate cancer, depending on which group you're in. And they also found, they were also looking for dying of anything in each group of men, the odds of getting metastases, the likelihood of treatments not working, clinical progression, and side effects. So this is a very big, important trial, and you'll see from the data that I'm going to present now. So, look here. If we look at the surveillance group, surgery group, and the radiation group, the 10-year likelihood of dying of prostate cancer for these men was 98.8%. That's the surveillance group, or 98.8% of not dying of this. So 1.2% risk of dying of prostate cancer if you're on the surveillance arm. Okay. 1% risk of dying from prostate cancer if you were in the surgery arm. And with radiation, about less than 1%. So there really isn't a big difference. Okay? Of course, in the active surveillance group, there were more men where the cancer progressed. After all, you are not treating these men, so about 20% of the men did progress. At the 10-year mark, there were more men with metastases. But ultimately, if you have metastases, it doesn't necessarily translate into a higher death rate. And if you look at the overall number of deaths, including prostate and non-prostate deaths, they're all about the same. So one take-home message here is, at the 10-year mark, prostate cancer doesn't kill people, the early stage prostate cancers. Don't kill, you have at least a 10-year window, okay? And there's a much higher likelihood, about 10% risk, that you're gonna die of something else, as opposed to a 1% risk of dying of prostate cancer. So there's a 10 times as high risk of dying of non-prostate cancer causes versus prostate cancer. So this study really put some weight behind the concept of active surveillance. Side effects. Okay. So if you had surgery, you have a higher likelihood of having erectile dysfunction. Even active surveillance men had erectile dysfunction simply from being older, and it's just unfortunately just a aging phenomenon. But if you had surgery, you're at least an 80% likelihood you're going to be not happy with your erections. With radiation, it is slightly higher risk of erectile dysfunction compared to active surveillance. And look here, about a quarter of the men, or a fifth of the men at the 3-year mark were wearing some pads if you did surgery. Okay. So, so there is a price to pay to get cured. Okay. So these are some of the sexual side effects. This is a little bit complicated. So if you look at basically the red line is the patients on who had surgery, and the red line basically shows you the percentage of men who had satisfactory sexual function after surgery. It's pretty low. Okay? And the likelihood, the red line here is showing you the men who are having problems with sexual function. So this is just another way of conveying that sexual function is impacted by surgery. Let's see here. So this is just a little cartoon. Urinary side effects. If you have, again, red line is surgery patients. If you have surgery, you have a higher risk of urinary problems, including incontinence, mainly incontinence actually. Okay. You guys heard enough? So, want to hear more? So, this is a patient who had radiation therapy. It wasn't that bad, but when they did the colonoscopy, this is what they saw. The normal colon is a whitish beige color. If you've had radiation therapy, parts of your colon becomes chronically inflamed, and this is what we call radiation proctitis. Okay? And this would manifest itself as bleeding, stool urgency, chronic diarrhea. Not as bad as this, of course. Okay. And this is a little, this is some data on bowel toxicity. And the main sufferers of bowel toxicity are the guys who did radiation therapy, not surgery, not active surveillance. And appropriately enough, the radiation therapy people arms, which are a little bit lower, these are satisfaction. Appropriately, their line is brown. And this here is the number of stools per day, a number of loose stools, likelihood of loose stools, likelihood of having some stool incontinence, and likelihood of having bloody stool. So this brown line is higher, representing the radiation people suffered more from a bowel problem. So important points about this PROTECT study. It's a 10-year study, so they followed these men for a long time. And a lot of these men, their cancers don't progress. So a lot of these men did not need treatment. Okay? But of course, some men did progress, including the patients who got surgery or radiation. So just because you do surgery and radiation, it's not necessarily a guarantee either. Okay? Ultimately, in this study, about half of the men at the 10-year mark did undergo some treatment. The radiation the outcomes for survival and relapse were about the same between the surgical arm and the radiation arm. In this study, the people who got radiation, they had a less advanced type of radiation therapy. So that may explain some of the higher toxicities. It is important to know that the men who did active surveillance, they were more likely to, at some point, receive androgen deprivation therapy. And again, most men died of non-prostate cancer causes. All right, so let's go to intermediate prostate cancer. So intermediate risk prostate cancer, I would characterize as patients with a Gleason score of 7. You could have no nodules, usually a small one. your PSA is greater than 10 but less than 20. There's more than 50% of the cores involved. And when one looks at the prostate, they see the cancer, but it's not so big that it's broken through the capsule or invading the seminal vesicle. But it's not a tiny cancer. And it's usually on the genetic testing, they have an intermediate risk genetic profile. And I believe Dr. Turner gave a little talk about genetic evaluation of prostate cancer a few months ago. A little bit background on how we traditionally treat intermediate risk prostate cancer. We usually treat them with the combination of radiation plus seeds or radiation alone. Those are the traditional options. Surgery is an option as well. This study was presented late last year as a first study to ask if seeds by itself is enough. Okay? And that's very important from a quality of life standpoint. So this study, called the RTOG No. study, they accrued almost 600 men, and half the men were receiving a combination of seeds plus external beam radiation therapy. The other half just had seeds alone. So there's no arm here where it's radiation alone. Okay? And these are all intermediate type patients. So let's look here. Let's look at the relapse data first. Oops, here we go. So the combination group actually had slightly more patients relapsing compared to the seeds by itself group. The combination group actually had more radiation directed to the prostate, but the seed group had less relapse. Okay? So it's hard to argue that this treatment is better, the combination. And then the risk of metastases were low for both groups. The risk of local progression, meaning cancer coming back and growing within the prostate, was low in both groups. So it's hard to argue that combo is better than single seeds. And the death rate, dying of anything in both groups, was low, but almost all of them were non-prostate cancer related. The only, of the 9 deaths, at most 1 person died of prostate cancer. But importantly, let's look at the side effects. The group that got seeds alone had less urinary side effects and bowel side effects, 1/3 versus 1/2. Okay? And grade 2 is medium annoyances. Severe annoyance is more grade 3. And even in the severe annoyance, the combination, of course, had more side effects. So you're really comparing a similarly effective treatment with less side effects. Okay. So we're looking at the take-home-message, as I said earlier, is doing seeds by itself seems equally good in terms of relapse, progression, and metastases with less side effects. Okay. Now, and these patients all had permanent seeds. One question that we're trying to ask is, do temporary seeds have the same effective benefit? And I think the answer will be yes as well. So let's talk a little bit more about high-risk patients. High-risk patients are men who have high Gleason scores, PSA 20, a large nodule on exam, lots of pores involved. On the imaging, we could see tumors breaking through the capsule or invading the seminal vesicle. And usually for these more dangerous cancers, you have to be more aggressive. So there's no active surveillance here. So we're usually considering surgery, and often with radiation afterwards, external beam with probably seeds, and there's usually some component of hormone therapy involved for these high-risk patients. So there's no one really, there hasn't been great definitive answers on which treatment is the best for these high-risk patients. So this was a important study published in late 2016 that looked at almost 500 men with bad cancer. And they were looked at retrospectively at patients at UCLA and Fox Chase over a 13-year period. And these 487 men were noted, half of them had radiation, about 87 of them had the combo radiation, and 170 of these men had surgery. A lot of these men who had radiation did get androgen deprivation. So let's look at a little bit about the types of patients who are in this study. Let's see here. So first thing is, you'll notice is the surgery patients were a little bit, or quite a bit younger than the radiation patients. The surgery patients, on average, even though they're high-risk patients, the whole study, on average, their PSAs were lower. Okay, so maybe on the surface, these patients their cancers were not as bad, and more than half of these patients, in the men who got surgery, they had no nodules on exam. When they had surgery, they found out that about 16% of these men had lymph nodes involved, and about 40% of these men had positive surgical margins. This is the outcomes. So a lot of these surgical patients ended up getting radiation. So half the men had radiation after surgery. So when you're looking at telling a patient, oh, you have high-risk prostate cancer and you need surgery, I think it's important to tell the patient, don't be shocked if you need radiation also, okay? And patients sometimes forget about that. And if you do have to get surgery and radiation, it is a lot more side effects. And about 40% of these men also needed androgen deprivation therapy. On the other hand, if you did radiation, a lot of these men needed hormone therapy on top of the radiation. So you're really looking at multiple combinations of treatment. And in terms of this study, the average duration of hormone therapy in the radiation group was 2 years, a little over 2 years, and in the combo group was about 8 months. So let's look at the results. Look at the relapse data here. 60% of the surgical group relapsed. Okay. About 20-something% in the radiation group men relapsed. The likelihood of having metastases away from the prostate was a little bit higher in the surgical group. Okay. Remember, the surgical group had the lower PSAs, and they were younger, and they also had less likelihood of having a nodule. Okay. The likelihood of dying from prostate cancer was fairly even, but it's hard to argue that surgery patients had a lower likelihood of dying of prostate cancer here, 12% here. And the overall, interesting, if you include the prostate cancer deaths and non-prostate cancer deaths, the total mortality was actually higher in the radiation groups. Okay. Why is that? It's maybe because the men who got radiation were on average 5 to 12 years older than the surgery group. That may be a factor. Or maybe there's some other non-cancer cause of death for these men. Is it hormone therapy, for example? Okay. But if we're looking at prostate cancer issues, it's hard to argue that surgery is the best treatment. Okay. And this is a graph of the likelihood of being alive and not having metastases. And actually, the group that did the best was the group that had the combined radiation plus seeds. So after, I think it's around 10 years, the likelihood of not having metastases is over 80%. Whereas if you did radiation or surgery, the likelihood of not having metastases was only 40%. So what can we deduce from this study? Number one, it's a retrospective study, so it's not the cleanest type of research. The follow-up is still fairly short, but it does seem like the combination of seeds plus radiation for this group of patients is the best in terms of relapsing, metastatic disease, and death from prostate cancer. Seems like surgery and radiation were equivalent. Over 50% of the men who had surgery needed radiation, and the people who had radiation and seeds were more likely to receive androgen deprivation. So every treatment has pros and cons. Okay? So are we afraid of the robotic prostatectomy yet? So let's talk a little bit about, for these high-risk patients, this was a very good study. Remember I said the prior study was a retrospective study, which is not the best. This was a prospective study comparing the combination versus radiation alone. And this is called the ASCEND trial. And basically this looked at 400 men, about half of them received radiation by itself, and the other half received a combination. And all of these men received a year of androgen deprivation therapy. And after 6 years of follow-up, the group that did not get seeds, they were twice as likely to relapse. So again, supporting combination for high-risk disease is probably the best. This is a new phenomenon, this drug called abiraterone. So abiraterone, or Zytiga, is a drug we use for metastatic castrate-resistant prostate cancer, meaning there's cancer outside the prostate and Lupron is no longer working. Okay. This study came out just a month ago looking at using abiraterone before Lupron stops working, so using it in the beginning. And what they did was, in England, they took almost 2,000 men whose average PSA is 53. Okay? So this is high-risk patients. Okay? And 3/4 of these men had metastases, either in the bones or the lymph nodes. We're just going to look at the 28% of these men who did not have metastases. These are the high-risk, non-metastatic patients. Okay? And we'll talk about this group in a little bit. So half of the group of men received the combo ADT plus abiraterone, and the other half just received androgen deprivation by itself. And about 40% of these men received radiation. It's basically the men who got lymph nodes involved and the men who did not have visible lymph node metastases. So 40% of this group of men did receive radiation to the pelvis. And these are the results. Look here, the group that got the combination had about a quarter of these men progressed, as opposed to the group that did not get abiraterone, about over half of the men progressed. If you look at overall survival, the group that got abiraterone was more likely to be alive at the 3-year mark. They're less likely to progress. And look at the difference between painful bones or broken bones. If you received hormone therapy alone, 200 out of these 1,000 men had painful or broken bones from cancer, as opposed to about 10% of these men had painful or broken bones. So by all these standards, adding abiraterone improves outcomes compared to not adding abiraterone. And this data just came out a month ago. So again, this is a figure showing survival. okay, and symptomatic free survival. The top line is all the men who were on abiraterone, and being on the top line is good, meaning you're not dying or you're not suffering, basically, okay, over time. And so, by all accounts, taking the abiraterone improves your odds of not dying and not suffering. And I just wanted to point out to this graph here, these are the men who did not have metastases. These are the high-risk groups, okay? So the high-risk groups without metastases, if you receive abiraterone, the likelihood of you doing well is close to 90% as opposed to about 70%. Okay? There's quite a difference in the outcome here. And this is overall survival. Again, patients don't, the death rate is low even with high-risk prostate cancer, but your death rate is even lower if you receive abiraterone. So right now, we're pretty much incorporating this to all our patients who are receiving hormone therapy in the beginning for high-risk or metastatic disease. How about relapse disease? So relapse disease is when you take your cancer out by surgery, or if you do radiation, you relapse, your PSA starts going up. Okay? So there's some new data on this as well. So traditionally, the treatment for relapsing after surgery is to basically radiate the prostate bed, radiate the area where the prostate used to be. Okay? And the success rate really varies. It could be as low as 20%, as high as 70%. It all depends on multiple factors, and that includes the Gleason score, the positive or negative margins, and the PSA level. Patients who have a low PSA level, patients whose PSA dropped really low after surgery, and patients whose doubling time is very slow, those are the guys who benefit from radiation therapy. Okay? And they could have as high as a 70% cure rate. But there's really no data for, we give people radiation and we just hope for the best and hope that it works. Okay? There hasn't been any data showing that adding hormone therapy to radiation makes a difference, okay? Until this year. Okay? And this year, there was a trial of adding bicalutamide, not Lupron, just bicalutamide, which is Casadice. And you're adding that to radiation therapy in these men who had surgery. Okay? And these are 700 or so men, all had radiation to the prostate area. And half of these men received bicalutamide, and the other half received the sugar pill. And what they were looking for is what happened to these groups of men. It was good that the average PSA was only 0.6. They were able to follow these men for 12 years. These men, the median age was 65 years old. So look over here. The relapse rate of the people who had radiation plus bicalutamide was 44% compared to 68%. So if you just did radiation, there's a 1 out of 3 chance that it will work. 2 out of 3 chance it's not going to work. And that's why we don't push for, that's why surgery plus radiation is not always a sure thing. And even though you can do it, it doesn't always work. However, if you're going to do radiation, I would add bicalutamide. That will improve your relapse likelihood. Okay? And this does translate at the 12-year mark. The likelihood of dying of prostate cancer is at least double if you did not receive bicalutamide. Okay? The overall survival was better in the combination arm by about 5%. And the number of people dying is double if you receive no bicalutamide. Again, a lot of men died of non-prostate cancer causes. So the take-home message is, even if you relapse after surgery and radiation, you're still have a good chance of not dying of prostate cancer at the 12-year mark. But if you want a better odds, take some bicalutamide. All right, let's see. All right, so this is another one of these graphs. Without going into too much, the bicalutamide people did better. I don't want to put everyone to sleep. We still got a little bit more. Let's go to metastatic disease. Metastatic disease is basically cancer that has left the prostate and that's visible on scans. So you could see some spots in the bones, some spots in the lymph nodes on a PET scan, some spots in the liver on a CAT scan. So these are all evidence of metastatic disease. Okay? The most common presentation is spots in the bones and spots in the lymph nodes. Spots in the liver is only about 10%. Okay? So how do we treat metastatic disease? So, okay, other than that, again, here's abiraterone again. Abiraterone, again, had some really exciting data a month ago. So, based on some studies from 2-3 years ago, we know that if you have metastatic disease, if you add chemotherapy early, in the beginning, you will extend a person's life quite significantly. Okay? Rather than wait till using chemotherapy at the end. So this question with abiraterone, called the Latitude trial, was, well, what about adding abiraterone instead of chemotherapy? Did you get a similar benefit? Okay. So they did answer that question with 1,200 men with metastatic disease, and a lot of them had high Gleason scores, liver or lung metastases, lots of bone mets, and half of the group received hormone therapy, the hammer, plus abiraterone, and the other half just received the hammer alone. Okay? And they followed these men for about 2.5 years. So what they found was the group that received the combination, of course, had a higher likelihood of survival, much delayed progression, meaning it took 3 years before there were some new spots on the scans, as opposed to a little bit over a year. Okay? It took almost 3 years before the patient's PSA started rising, as opposed to about 7 months. So these men, you give them hormone therapy or androgen deprivation therapy, it will stop working fairly soon. So adding the abiraterone definitely delays and prolongs the duration that hormone therapy works. And this does translate into all these endpoints that I described earlier. They also measured when did patients start complaining of pain. About 1.5 years after starting treatment for the group that did not get abiraterone, but if you had abiraterone, at the 2.5-3 year mark, there wasn't any, very few complaints of pain. Again, these are graphs demonstrating the superiority of abiraterone in the previous endpoints that I went over. So abiraterone is definitely something we use for newly diagnosed metastatic disease. We use it with hormone therapy. And high-risk disease, we use it with hormone therapy to improve outcomes. Okay. So what about, this is a very interesting question. What about, there's always been, the traditional thought is if cancer has metastasized, what's the point of treating the mothership? And when I started in this field 15, 16 years ago, it didn't make sense to treat the prostate when there's already metastatic disease. Okay? But we've learned that in men who have localized disease, if you treat the prostate with radiation on top of hormones, it is better than hormones alone. And there are some other cancers where if you treat the mothership, overall patients live longer. So there is there is some research looking into this phenomenon. And I can't give you definitive proof yet, but let's go over some of this new data. Okay? So this was a retrospective study looking at, they reviewed about 6,000 men with metastatic disease who were treated with androgen deprivation therapy. They also found that of these men who were treated with ADT, about 500 of these men also had radiation to their prostate. So the question was, did this group of men do better than the group that did not receive radiation therapy? Lo and behold, interestingly, the group that got radiation had better survival on all criteria. Longer survival, likelihood of being alive at 3 years, 5 years, and 8 years for these men who had radiation to the prostate. So, interesting. So we got to keep an open mind about still considering treating the prostate. And this is again a curve showing the group that did the combination did better. Of course, we have to take this with a grain of salt because this is just an observational, not a prospective definitive study. The standard of care is still to treat with systemic therapy. On the other hand, radiation is safe. The newer types of radiation have less side effects. And there is still a role in radiation if we want to prevent symptoms, treat symptoms, such as pain, blockage, bleeding. So there is a role in radiation, but if we treat these patients for symptoms, maybe they'll live longer even though we didn't radiate the whole body. Okay. So therefore, I would still consider radiation as a potentially beneficial modality in this situation. And one of the primary cancers that we see this benefit in is if someone who has metastatic kidney cancer, if we take the kidney out, sometimes the patients actually live longer, even though they have metastatic disease. We don't see that in breast cancer, though. All right, so another new concept in 2016 and 17 is the concept of oligometastases. So usually we think of metastatic disease, as I showed you earlier, as a systemic disease with multiple spots, okay? And of course, the treatment is treat the whole body, okay? Now that we have all these newer scans, we're detecting metastatic disease significantly earlier, okay? And instead of seeing 10, 15 spots, we're seeing one spot, okay? And so it's hard to argue that this person should be treated the same as the person who has 15 spots, and their prognosis is different. Okay? So, in addition to treating the whole body, is there any role in treating that one spot directly? Okay? So, in addition to hormones, abiraterone, chemotherapy, is there a benefit in zapping or removing that one spot? Okay? Well, it could help with palliation, so if someone has pain in that spot, we could improve the pain. We could help patients go on a remission and maybe not even start Lupron, or allow them to stop Lupron. That's a big benefit already. And thirdly, is there a chance someone will live longer by simply zapping that one spot? Okay. So we know that when patients have surgery and they take their lymph nodes out and the patient has 1 or 2 lymph nodes that they coincidentally discovered with cancer and they removed it, that's actually an oligometastases. And these men, up to 40% of these men can have a very long-term remission before they need any other treatment, such as hormone therapy. So there is some rationale in treating oligometastases. We also know that the fewer metastases you have, the better you do. We also know that in a study by Dr. Abdullah, that when you radiate the pelvis, assuming there's some cancer there after surgery, patients live longer. Even though, let's say there's some cancer in the pelvis we radiated, who's to say that there's no cancer above the radiation field? But still, if you radiate the pelvis, a lot of these men live longer. So, how do we treat it? Well, as I talked about earlier, we could remove it during surgery, or we could direct some radiation to the specific oligometastases. And so, one way to, let's go over a little bit about radiation for oligometastases. You could give it over 3 to 7 weeks, you could give it over 1 to 2 weeks, you could give it over 1 to 2 days. These are various types of radiation. And as discussed earlier, it's to prevent complications, it's to treat pain, and maybe it could help someone live longer. Why even consider radiation? Well, because it is a lot safer than before. They're able to pinpoint the radiation to one spot without as much radiation scatter and damage to the other parts of the body. And I know some of these patients, a couple of these patients in this room have undergone this type of treatment. And so this was a review from 2 years ago of 15 studies, 450 men. What happened to these men who had treatment for oligometastases? Well, number one, these men had fairly low PSAs, so their cancer was discovered with these scans, probably the newer scans that are able to discover small amounts of cancer. 98% of these men were discovered via these PET scans. Okay? And most of the patients had lymph node disease. About a quarter of these men had skeletal metastases, like 1 or 2 spots in the bones. And 4 of these men had liver-only or lung-only oligometastases. And in treatment, 2/3 of the men had radiation, 1/3 had surgery. And these are, of the patients who had radiation, a lot of these men received some hormone therapy. About 70% of the men received some hormone therapy. And of this men who had surgery, a lot of the men had an average of about 11 lymph nodes removed, and the average number containing cancer was 2. Okay, so there's less benefit when there's 11 of 11 lymph nodes with cancer. Okay. And a third of the men who had surgery had radiation, and about half of the men also received androgen deprivation. So what happened to these men? The success rate of controlling the cancer with radiation is really good. So of that spot ever causing problems is less than 5%. Okay? So there's a benefit there. And the duration before a new spot popped up was anywhere between 15 and 57 months. Okay. So it's not like you zap the one spot and 2 months later another spot comes up. That's not very beneficial. If you zap one spot and there's another 1 to 5 years before you have to worry about another spot, that's not so good. And of the men who had surgery, about 50% of the men, their cancer was stable. No new problems. Okay. So this data looks fairly reasonable to consider. And I put this in a survival table. Everything above this gray bar are the radiation patients who received either a short course of hormone therapy. About a third of these men had no progression at the 2-year mark. Half of these men had no progression at the 3-year mark, about 50 patients per study. In the 59 people who had surgery at a PSA of 2, over a third of these men still had no progression, meaning no hormones, or no retreatment of hormones. That's pretty good. Okay. And if you got surgery when the PSA is higher, the numbers are not as good, but still 40% chance of not having disease progression. So this retrospective data makes us think that treating oligometastases, even when we know this is a systemic disease, might have some benefit. Again, it's not enough data to say we should do this for everyone. It's very good we know that it controls the cancer at the spot. It's very well tolerated in my experience, especially with the new ways of treatment. We can't say people are going to live longer just because they examine one spot. Okay? But I think other than needing more studies, we won't know the definitive answers for a few years. But I do feel like it's a good way to give the patient a break from hormone therapy. It might allow them to delay starting hormone therapy, which, as many of you guys know, is a great benefit already. And will it maybe even delay hormone-resistant disease? So those are questions or potential benefits of treating oligometastases. A little bit about metastatic disease again. The traditional treatments we have for metastatic disease, which you guys probably know about, are androgen deprivation therapy, abiraterone, enzalutamide, Taxotere, and cabazitaxel. These are chemotherapies. Radium-223, which is basically I call it liquid radiation. And these are all approved treatments that have been around for about 4 years. The last of these were approved about 3 years ago. Okay. So what's the next frontier? The next frontier is hopefully some improved immunotherapy. The first immunotherapy that was approved 6 years ago was Provenge, and we still use that. But we're hoping that these new immunotherapy treatments get approved and will give us some good data and then get approved. And we'll talk a little bit about high-dose testosterone. So what is this PD-1 inhibition? It's easiest for me to explain it with this cartoon. This is a cancer cell. This is the immune cell, a T cell. And cancer cells have a way of binding the PD-1 receptor on the immune cell. Once it binds onto the immune cell, it actually disables the immune cell from killing it. Okay? So it's very tricky. Okay? So the scientists have discovered a way of preventing the cancer cell from clamping onto this receptor. By preventing the clamping on of the receptor, it's allowing the immune cell to attack the cancer. So this is called PD-1 inhibition. And there's about 6 different drugs for about 7 or 8 different cancers where PD-1 inhibition has helped. Melanoma, lung cancer, kidney cancer, bladder cancer, lymphoma. So lots of cancers are showing decent data that these immune treatments are helping. For example, Jimmy Carter, he had a brain tumor, and he got this PD-1 inhibitor that basically put him into remission. So we don't have enough data to say we should give immune treatment, PD-1 inhibitor, to all prostate cancer patients. But we are getting some data. The first data came out last year at the European Society of Medical Oncology, and they treated these patients who have castrate-resistant prostate cancer with a drug called Keytruda. And they treated about 23 patients, and what they found that 3 of the 23 men had a good response, and their cancer was controlled for over a year. And these are men with pretty advanced disease who've progressed with multiple treatments. So getting 3 men, not a lot, to respond, but is not the greatest number, but the response was pretty good. The most important thing was another 9 men, their cancer stopped growing. Okay. So the immune system's helping contain the cancer. So all in all, we're looking about half of the men who received Keytruda seem to have benefited. There are some side effects, including nausea, fatigue, rash, shortness of breath. Those are possible side effects. So for this heavily pretreated group in a small study, there seems to be some benefit. Another study using Keytruda again studied 20 men. All these men were castrate-resistant, and they progressed on Xtandi. And these men received Keytruda, and 4 of the 20 men, they had a PSA of less than 0.1 after Keytruda. That was pretty impressive. And it took anywhere between 4 months to over a year before the cancer progressed. So it seems to control the cancer for a medium amount of time. And another 7 men had stable disease. So again, 11 out of 20 men seemed to have some benefit from Keytruda. Okay. Again, there were some side effects, including diarrhea, thyroid problems, muscle issues. Okay. This study just came out a month ago, done at the NCI in Bethesda, and they took 25 men who also had really bad disease. They progressed on abiraterone and or enzalutamide, and so far they've treated 10 people. The average PSA was 86, and they gave this combination. This is another PD-1 inhibitor, but they paired it up with this ovarian cancer drug called olaparib. And this combination, they saw that 5 of the 7 men that they evaluated had a 50% drop. Okay. And in fact, 3 of these guys, their PSA dropped by anywhere between 79 to 99%. Again, sick group of men, multiple prior drugs, new combination, looks pretty good. Right? So there's reason to be optimistic for immune treatments. Okay. So these are some of the active trials going on with immune treatments. All these drugs, first drugs here, are all PD-1 inhibitors. Darolutamide, Keytruda, Tecentriq, Opdivo. And they're using them in combination with other medicines. Some in combinations that are available, some in combinations of Yervoy, which is used in melanoma, olaparib, which is used in ovarian cancer. So we'll get some data maybe in pretty near future, probably next year. Okay. Xofigo, I referred to that earlier. Xofigo is basically a treatment for castrate-resistant disease. I call it liquid radiation. It gets injected into your veins, and the bones think it's calcium and take it up. And they take up this compound called radium. Okay? They mistake it for calcium. So when the bones take up this radium, once it goes into the bone marrow, it releases radiation and it kills some cancer cells. So it's very targeted. So by definition, this only treats cancer in the bones. Doesn't do anything for a cancer in the liver or lymph nodes. But it does prolong survival, and this was approved 3 years ago. This is I'm going to show you a new treatment with liquid radiation called lutetium. And this was a study presented early this year by a group in Germany. Very sick patients who had a lot of cancer, and after lutetium, their cancer basically disappeared. And this is a new generation liquid radiation that goes into the bones and the lymph nodes. And this guy, I'm showing you the best response, of course. This guy had a PSA of 380, and at the end of treatment, his PSA dropped to about 1 from lutetium. Exciting stuff. And UCLA is having a study with this drug treatment starting in September. In the meantime, I've sent some patients to Germany, and I've sent one patient to Australia to get this treatment. But UCLA and Cornell will have it very soon. So stay tuned for this. All right, so let's end on a very controversial and interesting note. Bipolar androgen therapy. Basically, it's for what happens if you give testosterone to someone who's already castrate resistant. Okay. So this, I was inspired by a famous orange-colored hair man, and let's go over some of the data. You guys know who I'm talking about? All right. So let's make testosterone great again. So the first inkling of maybe overloading the cancer with testosterone was studied by Dr. Schweitzer for these men who are castrate resistant, and he found some men who benefited. Very small studies. A larger study by Dr. Denmead was subsequently, the data was released, press released at the end of last year. Finally, the data came out a month ago in terms of details. So what they did was 30 men who are metastatic, castrate resistant, Xtandi stopped working, but they didn't have terrible cancer, but they just had some metastatic disease, and they weren't suffering from the cancer. So probably a low volume metastatic disease. They don't want to find someone who has florid cancer and then give testosterone and see what happens, right? So they took this fairly safer group of metastatic disease patients and kept them on hormone therapy, but once a month gave them a big shot of testosterone and just kind of overloaded their body with testosterone. Okay? And 400 milligrams injected once a month. And the patient's testosterone went up and then dropped in about a week or two. And during this month, some men got hornier, some men felt a little better, and 9 out of 30 of these men had a PSA drop. Crazy, right? Who would have thought? So about a third of these men had a PSA drop, and this worked for about 8 months. What happened to about three of them? One had a heart attack. Is it the testosterone? Is it the horniness? What happened, you know? One guy had a blood clot, you know, that went into his lungs. Another guy, his prostate cancer got so big and the lymph nodes got so big it blocked his bladder. And 2 of these 30 men, they did have more pain for a while. So probably some men benefit, but it might be risky in other men. So it's very provocative data. Now, ideally, we find a way to pick which men will benefit and which men will not suffer from this. So we shall see, right? But this is very interesting. I think we'll get more data in the next 2 to 3 years. Okay. So to summarize this whirlwind of prostate cancer, back to low and intermediate risk patients, the take-home message is the 10-year survival for surgery, radiation, and active surveillance is the same. So one could consider active surveillance. For intermediate risk patients, it seems like seeds is just as good as the combination of seeds plus radiation therapy. For high-risk patients, seeds and radiation is, in my opinion, probably the best approach. And using abiraterone early should help as well. This is good data, okay? And the new standard of care, by the way. For relapse patients, if you were to get radiation therapy, taking 2 years of Casodex will improve your odds. If you have metastatic disease, maybe treat the prostate, maybe treat a single lesion. Of course, we need more research. We have more data on abiraterone this year for using it early rather than at the end. Okay. And there are going to be newer immunotherapy combinations. There's even newer liquid radiations, newer than the lutetium that I referred to. So we'll get more data on that in the next couple of years. And these are some of the interesting trials coming up. We should get some data on these within the next 1 to 2 years. Especially this year, we'll get more data on olaparib. This ARV7 is a kind of in vogue topic. It's a type of mutated cancer that we may be able to find some specific treatments for. Cancer genetics. There's probably 50 different metastatic prostate cancers. Maybe we could pick a specific treatment for that specific cancer. Maybe we don't have to treat everyone in a cookbook fashion. And of course, the newer generation liquid radiation therapies. So on that note, I want to thank everyone's attention and wake everyone up. And I'm here for some questions if you guys have them.
We need to
rent. We have to pay Charles's high salary here. And then we will, at the same time, if we can pass this on back, and if you have questions, raise your hand and we'll give you the mic.
Thank you.
Larry Borman.
Thank you for an excellent presentation here today, and I want the audience to know that the speaker that we originally had scheduled here for today was unable to do it. We asked Dr. Lam to come and give the speech, and he, without hesitation, came and joined us and gave an excellent presentation. Thank you. My question is that Keytruda is being studied in many different institutions across the United States. One of the institutions that studied it is University of California, Irvine, and they're combining it with the OLA-PARID. Have you heard anything that you could share with us about that?
Not yet from Irvine. The study that I showed earlier with durvalumab, which is a cousin of Keytruda,
Okay.
with olaparib. So that looked really promising. So it's
It seems that the combination is more efficacious than the Keytruda by itself. Would you agree, disagree?
I would agree. Yeah.
Yeah.
Now there's a lot of 2 is frequently better, but it doesn't always mean better survival, because 2 means more side effects and more risk. But sometimes we use 2 drugs. Now we're using abiraterone plus Lupron. So it's always we always got to balance that with side effects.
As you explained it, the Keytruda unmasks the gene, okay, that masks the cancer, or excuse me, the Keytruda, allowing the Keytruda to see the cancer in the cell. It seems, if I have the mechanics down correctly, it would seem that the second drug would have a greater opportunity to injure the cancer cell or kill it.
Right. I mean, it's always better to find 2 different mechanisms to attack the enemy, and so that's why there's all these combination trials.
Thank you.
Of course.
You covered a lot of different therapies, but one thing I didn't see was, what if you do just triple blockade by itself?
So triple blockade by itself is an excellent way to control cancer. And a lot of it depends on what you're trying to achieve. So triple blockade is another name for a type of anti-hormone therapy, basically. And triple blockade controls cancer. If your goal is to maybe cure someone, then triple blockade, it doesn't always cure. And eventually, patients there's a very high likelihood they'll relapse. It could be 3 years, 5 years, 7 years. It just doesn't last forever. Now, sometimes you do triple blockade, and then you do chemotherapy, and then you do thalidomide, Revlimid. That's no longer triple blockade. That's triple blockade plus a bunch of stuff. So those are really good ways to control cancer. But for early stage, I don't even think you need treatment. So I wouldn't give triple blockade for early stage. Remember, triple blockade has side effects as well. Okay? And if you have intermediate or intermediate risk prostate cancer, but you want to get cured, you may do triple blockade or consider radiation or something to get cured. If you have advanced disease, triple blockade works really well.
I noticed you didn't say
I noticed you didn't say anything about being cured up there, just survival.
I talked about for localized disease, a lot of the treatment options are surgery, radiation, seeds. For those localized disease, one can still get cured. For metastatic disease, we're looking at control and survival. So, it's such a big topic, prostate cancer, and we could go on for 10 hours and not answer everybody's specific situation.
Doctor, I don't think I need a microphone. Are these therapies available at your local urologist on the corner, or are they only available primarily through teaching and medical schools, or what is the availability of a lot of these techniques and therapies?
A lot of again, it depends. I think with some radiation's available, surgery's available, hormone therapy is available, abiraterone is available, chemotherapy is available, enzalutamide is available. Immune therapies, you need to be on a trial. These special radiation beams, it's available. So a lot of stuff you don't need to go to, Harvard or something or travel too far.
You mentioned HIFU as a treatment, but you didn't really compare it to treatment options.
Yes. So, if I get invited back and to talk about treatment options to cure, we could go over how to compare surgery, radiation, seeds, HIFU, cryo. I'm kidding, but HIFU does work. It is basically using sound waves to heat up the prostate. And they're able to heat up part of the prostate as a way of getting rid of the cancer there. It's pretty effective. It still could cause some erection problems. It could cause something called fistulas. And even though it got approved, so far, as far as I'm aware, it's still not paid for by Medicare yet. So it's about $25,000 at USC. The challenge with HIFU is, there's still a decent risk that the cancer will come back in the same area. So you spend your $25,000, you heat up that area, looks great for a few years, it comes back 5 years later. Do you do it again? Do you do radiation? I don't know.
Yeah, the HIFU, I kind of connect with it like trying to pop every kernel in a bag of popcorn. I compare HIFU, which was offered after my radiation treatment at City Hall at USC. I went to the lecture on that. But I reckon it, or compare it to trying to pop a bag of popcorn. And no matter how long or how intense the radiation is, you get to that bottom of the bag and there's always a few kernels that have never been popped. Is that a comparison? I mean, can we look at the cancer that way? Meaning, with HIFU, are you missing some of those cells? You didn't get them hot enough, or they just didn't pop and die on you?
With almost all treatments, that popcorn analogy applies.
Okay.
You do radiation, seeds, HIFU, cryo, hormone therapy. You miss the last few kernels. Okay. So that's the problem with cancer. You hear the analogy, at the end of the world, the big meteorite destroys Earth. What's left? There's some cockroaches there. So there's always going to be a little bit around. So
for low intermediate disease where you're doing radiation, is hormone therapy advised at that time as well?
So for low risk, low intermediate, you don't have to. Sometimes a short course, like 4 to 6 months of androgen deprivation, will help a little bit. So if your cure rate's 80% and you do 4 to 6 months of hormones, it might be 86%.
Do you do that first, the hormone?
You do it in the beginning, in combination. So radiation usually takes 6 to 9 weeks.
And say say you're doing SBRT, same thing.
So yeah, you usually would do some hormones in the beginning for maybe 4 months. And in that 4 month, you get the SBRT in, usually after 2 months. Well, on that note, I want to thank everyone for attending and asking these good questions, and we'll call it a night.
Thank you for watching our video. If you would like to learn all the most current prostate cancer information, we have many YouTube videos on our website at www.prostateforum.org. We also have meetings the fourth Thursday of every month where you can talk to mutual survivors. You can also ask personal questions to the doctors and the speakers after the meeting. Remember, when us men hear the word cancer, the big C, our brains turn to mush. We think we're about to die. Come learn where there's hope and information at the Prostate Forum of Orange County.